Good morning. This is Dr. Cindy Herndon, and I'm going to present to you cellular regulation module 2 regarding prostate cancer. And we're going to be looking at Exemplar 2G for prostate cancer today. And here are your learning objectives. We're going to analyze prostate cancer as it relates to cellular regulation, and we're going to describe the pathophysiology of prostate cancer, describe the etiology of prostate cancer, compare the risk factors for and prevention of prostate cancer, identify the clinical manifestations of prostate cancer, and summarize diagnostic tests and therapies used by interprofessional teams in the collaborative care of an individual with prostate cancer. We're also going to differentiate considerations for care of patients with prostate cancer across the lifespan and apply the nursing process in providing culturally competent care to an individual with prostate cancer. Cancer of the prostate is the most common type of cancer and the second leading cause of death among men in North America. It is primarily a disease of older men, and the incidence increases with age, and the majority of diagnosed cases in men older than 65. So we have that. It is primarily a cancer for men older than 65. The death rate is decreasing as a result of advances in diagnosis and treatment. In prostate cancer, abnormal growth of prostate tissue may be related to benign prostatic hyperplasia, or it may be an indication of prostate cancer. The diagnosis of prostate cancer is frightening for most men who fear death, disfigurement, and loss of sexual function. When diagnosed early, prostate cancer is curable. When the cancer is confined to the prostate at diagnosis, the 5-year survival rate is 100%. Even when the cancer has spread regionally, approximately 98% of patients are alive after 5 years. More than 90% of prostate cancer diagnoses are made in one of the states I just described, confined to prostate or spread regionally. Many men are found to have prostate cancer upon autopsy, in which the cancer usually has not produced manifestations of or complications of, and the men died not knowing they had the disease. My dad actually had prostate cancer, and I remember a pharmacist saying that most men will develop prostate cancer if they live long enough, but it will not be the disease that usually kills them. It will be something else. And of course, my dad did die of a heart attack, so that and heart failure. So that was true for him. The prostate gland consists primarily of glandular epithelial cells. The exact etiology of prostate cancer is unknown, although androgens are believed to have a role in its development. Almost all primary prostate cancers are adenocarcinomas, and they develop in the peripheral zones of the prostate gland. This location increases the risk of local spread to the prostatic capsules. Despite the proximity to the rectum, metastasis of the bowel is uncommon because the retroprostatic fascia acts as a physical barrier. As the tumor enlarges, it may compress the urethra and obstruct urinary flow. The tumor may metastasize and involve seminal vesicles or bladder by direct extension. Metastasis by lymph and venous channels is common. Researchers believe prostate cancer to be linked to changes in DNA of the normal prostate cell. Inherited genetic mutations have been linked to hereditary prostate cancer. The mutated genes include RNASFL, BRCA1, BRCA2, MS2, MLH1, and HOXB13. Men with these mutations have increased risk for prostate cancer. Research has suggested a relationship between acquired genetic mutations caused by increased hormone levels and inflammation and the development of prostate cancer, and other studies have not found this to be correlated. Additional research is needed in this area. And the risk factors here, the greatest risk factor for prostate cancer is, of course, age. Approximately 1 in 12 men aged 70 years and older will be diagnosed with prostate cancer. Race is also a significant factor. African American men are at particularly high risk, according to recent studies. A diet high in dairy foods or processed meat may increase the risk for developing prostate cancer, and obesity may also increase the risk for aggressive form of prostate diseases. Some research suggests that firefighters may be at a higher risk for developing prostate cancer. Genetic factors and hereditary factors such as having a family member with prostate cancer are currently being researched. Men who have had a vasectomy are believed to have increased levels of circulating free testosterone, and this is being researched. And dietary factors such as a diet high in animal fat and excessive supplemental vitamin A are all being researched currently. Prevention of prostate cancer through the use of medications is a prominent area of research. The drug dutasteride and finasteride reduce the amount of certain male hormones and are already being used in the management of symptoms related to benign prostate hypertrophy. Neither of these two drugs have approval for the prevention of prostate cancer. However, they do appear to lower the risk of prostate cancer. Side effects such as risk of erectile dysfunction and diminished libido make these drugs less than ideal for use for prophylactic treatments. Screening recommendations center on optimal timing for discussing benefits and limitations associated with available tests for early prostate cancer detection. The guidelines are for men at average risk of prostate cancer and whose life expectancy is at least 10 years. The discussion and informed discussion should begin at age 50. For men at high risk for developing prostate cancer, including those whose close relative was diagnosed with prostate cancer before the age of 65, and those who are African American, this discussion and informed decision should begin at age 45. For men at even higher risk, including those for whom several close relatives have been diagnosed with prostate cancer at an early age, this discussion and informed decision about testing should begin at age 40. Men with early stage prostate cancer often have no symptoms. Pain from metastasis to bones is frequently the initial symptom that's noted. Urinary manifestations depend on the size and location of the tumor and on the stage of the malignancy. Symptoms are often similar to benign prostatic hyperplasia such as urgency, frequency, hesitancy, dysuria, and nocturia. The man also may notice hematuria or blood in the ejaculate. On page 133, there is a table on clinical manifestations and the therapies used. Care of the patient with prostate cancer focuses on diagnosis, elimination, or containment of the cancer and prevention or treatment of complications. Early detection remains a major emphasis for control of prostate cancer. The treatment of prostate cancer depends on the grade and stage of the cancer as well as on the age, general health, and preference of the patient. Sometimes when the patient has a slow-growing tumor and is older or has a limited life expectancy, watchful waiting is the treatment of choice. Treatments for prostate cancer include surgery, radiation, therapy, and hormone manipulation. Regardless of whether the patient has locally advanced cancer or distant metastasis at the time of diagnosis, an increasing number of patients are being diagnosed with asymptomatic prostate cancer. The definitive diagnosis can only be made with biopsy, which is very painful. However, other tests may suggest the presence of prostate cancer. The prostate gland will be nodular and fixed during a digital rectal exam. Levels of prostate-specific antigen, or PSA, are used to screen for prostate cancer and to monitor initial response to the treatment. A PSA level of 4.0 or lower is considered normal, or age-adjusted PSA levels are considered by providers based upon their age and the health history. A small but significant number of men with prostate cancer can present with a PSA level below 4.0. Therefore, identification of risk factors is very important when the provider is considering a biopsy. Prostatitis, urinary tract infection, and certain medications, as well as herbal supplements, can elevate the PSA level or cause the PSA level to fluctuate. Prior to prostate biopsy, additional testing such as X-rays and cystoscopy may be warranted to rule out other causes of elevated PSA. Transrectal ultrasonography, or a TRUS, may be used when the digital rectal exam is abnormal or when the PSA is elevated without other apparent causes. With the TRUS, a small probe is inserted in the rectum. The probe gives off sound waves that creates a picture of the prostate on a video screen. The healthcare provider uses this picture to insert a narrow needle through the rectal wall into the prostate gland and uses the needle to collect a sample of tissue for examination. Other tests include a urinalysis or cystoscopy. Bone scan MRI or CT may be performed to determine tumor metastasis. If prostate cancer is diagnosed, the grade and stage help determine the prognosis and to guide treatment decisions. The grade is the cancer cell differentiation and is determined by the pathologist. Prostate cancer is staged with a variety of tests, and treatment options are outlined in Table 216 on page 134. Prostatectomy is the removal of all or part of the prostate. The transurethral resection of the prostate, or TURP, involves removal of parts of the prostate gland by a surgical instrument that's inserted into the end of the penis and through the urethra. For very early disease in older men, TURP may achieve cure of prostate cancer. Radical prostatectomy is the removal of the prostate capsule, seminal vesicles, and a portion of the bladder neck. Complications of this procedure may include erectile dysfunction, urethral stricture, fistula, rectal injury, and urinary incontinence. A more recent treatment is laparoscopic radical prostatectomy, in which small incisions are made in the abdomen and a laparoscope is inserted and used to remove the prostate. Retropubic prostatectomy may be performed because it allows adequate control of bleeding and visualization of the prostate bed and the bladder neck, as well as access to the pelvic lymph nodes. This is the favored surgical method currently. Perineal prostatectomy is often performed for older men or those who are poor surgical risk, and this approach requires less time and involves less bleeding. Suprapubic prostatectomy is rarely used, but may be done when problems of the bladder are expected. Control of bleeding is difficult with this procedure because the surgery is complicated and is completed going through the bladder. For patients with stage 3 prostate cancer that is locally advanced beyond the prostatic capsule, surgery is controversial because of the likelihood of hidden node metastasis and relapse. TURP is not performed as a curative therapy for patients with advanced disease such as stage 3 and 4, but it may be used to relieve urinary obstruction. Surgical intervention is now available for men with urinary sphincter insufficiency, which is usually the cause of urinary incontinence after the prostatectomy. An artificial urinary sphincter is implanted. during this time. In order to be a candidate for this procedure, the man must be able to recognize when there is a problem and be able to manipulate the pump placed in the scrotum. Androgen deprivation therapy is used to treat advanced prostate cancer, and this therapy causes cells in the growing tumor to die or to stop growing due to the androgen deprivation. Some cancer cells thrive without androgen and are unaffected by therapy that reduces circulating androgens. The effects of hormone manipulations vary from complete but temporary regression of the tumor to no response at all. Strategies to induce androgen deprivation include orchiectomy, that is unilateral or bilateral, or oral administration of hormonal agents. And you have a table 2.17 on page 136 that compares surgical and hormone therapies and the advantages and disadvantages of each. Radiation therapy may be used as a primary treatment for prostate cancer because it reduces the risk of long-term problems such as impotence and urinary incontinence associated with the surgery. Radiation is delivered by external beam or interstitial implants of radioactive seeds of iodine, palladium, gold, or iridium. Interstitial radiation has a lower risk of rectal damage and impotence than external beam radiation. Radiation therapy has a palliative role for patients with metastatic prostate cancer to reduce the size of bone metastasis, assist with pain control, and restore functions such as incontinence. Diet is a non-pharmacological factor that can be easily addressed. Men should be informed that they can lower their risk of prostate cancer by consuming a diet that limits dairy products and processed meats. The nurse should advise patients to follow the recommended balanced nutrition of fruits and vegetables as outlined in the federal government's Choose My Plate guidelines, and we'll look more at this when we have a face-to-face class. And for lifespan considerations, prostate cancer is usually diagnosed in older men, as I said earlier. However, the number of younger men being diagnosed with prostate cancer has significantly increased over the past 20 years. Prostate cancer is rarely diagnosed prior to 40 years of age, with 4 out of 10 cases being in men younger than 66. This cancer is usually slow growing, and men who are diagnosed usually die from other causes, as I mentioned earlier. Early onset prostate cancer is defined as prostate cancer diagnosed prior to age 55 and is thought to be due to genetic factors. This early onset prostate cancer diagnosis accounts for approximately 10% of diagnosed prostate cancers. Research indicates that prostate cancers are increasing among young men aged 15 to 39 worldwide, and these cancers tend to be more aggressive and are 6 times more likely to have developed metastasis at the time of diagnosis. These men have poor 5-year survival rates, and of course more research is needed to discover how these cancers differ from cancers in older men. Nurses plan and implement interventions to assist in prevention of prostate cancer and to facilitate a return to functional health status once prostate cancer is diagnosed. Nurses increase public awareness about early detection of prostate cancer by taking every opportunity to share and inform men and families about early detection of prostate cancer. Collect the following data or cues from the patient's health history and physical examination. Observe the patient for signs of discomfort and pain in the spine, hips, or other bones, and for signs of weakness or numbness in legs and feet, which could be indicative of spinal cord compression from a possible tumor. Ask the patient about risk factors, urinary elimination patterns and manifestations, hematuria, and pain. during the physical exam include the digital rectal exam. Now, this is an advanced nursing assessment technique, so the ADN nurse cannot do this, but if you progress to advanced nursing practice, you will be able to do that. But in this digital rectal exam, we are assessing prostate size, symmetry, firmness, and nodules, the presence of nodules. And you can just know these symptoms so that if this is found by a doctor or a nurse practitioner, then you will know that this is what they're looking for. Assess for bladder distension, urinary flow, and urinary retention. Medical diagnosis and or nursing hypotheses that may be relevant for patients with prostate cancer may include urinary incontinence, urinary retention, stress incontinence, sexual dysfunction, and discomfort. Goals of nursing care may include that the patient will express concerns and emotions related to his diagnosis and the potential effects of treatment. The patient will demonstrate optimal urinary function, including urinary elimination of at least 0.5 milliliters per kilogram per hour, and the patient will verbalize awareness of strategies for promoting urinary continence. The patient will demonstrate the ability to make informed decisions regarding all treatments. Using a pain rating scale, the patient will report his pain is maintained at a level deemed by him to be tolerable. Nursing care must be provided with sensitivity because patients are often worried about the loss of virility, sexual function, and masculinity, and they may be reluctant to discuss these concerns with the nurse. Holistic care must be provided to meet the patient's physical, psychological, and spiritual needs. Urinary incontinence is a very disturbing complication following prostate cancer treatment. Both radical prostatectomy and external beam radiation treatment can cause incontinence, ranging from stress incontinence to complete and unpredictable loss of control of total incontinence. Older men may experience urge incontinence. Nursing interventions appropriate for implementation and the promotion of optimal urinary elimination patterns include assessing the degree of incontinence and the effects of the patient's lifestyle. You will need to determine previous urinary patterns and the type of incontinence the patient's experiencing. You'll need to teach Kegel exercises to help restore the continence. Pelvic muscles or Kegel exercises can improve, eliminate stress incontinence. Encourage the patient to verbalize his feelings about the impact of incontinence on his quality of life. The degree of incontinence does not necessarily correlate with perceived level of suffering for the patient. Listening to the patient's concern with sensitivity can assist the patient to work through these feelings and allow him to move forward to a healthy adaptation to his condition. The nurse will need to teach methods to control dampness from incontinence and do not restrict fluids, which would have many negative effects, even though the patient is probably going to be worried about the incontinence episodes, but they still need their fluids. Encourage the patients to wear absorbent pads inside their underwear and change as needed. And the nurse will encourage appropriate measures to promote good hygiene and decrease anxiety and increase comfort. Refer to the physical therapy or a continence specialist for additional measures to promote continence. And there are special exercises restricting some types of fluid and other measures such as bladder training that can help us and assist the patient to deal with these experiences of incontinence. You can explore other options such as an external collection device and an external catheter for the patient with total incontinence. And this may improve their self-esteem and allow resumption of social activities for the man. Surgical treatment for prostate cancer may cause erectile dysfunction and changes in the ejaculatory function. Hormone therapy for advanced prostate cancer lowers libido and could cause erectile dysfunction also. The diagnosis of cancer and the body image changes caused by hormone therapy may lower the man's self-esteem, which can diminish sexual desire and willingness to be sexually active. Most older men are sexually active and fully capable of sustaining an erection. Men are likely to fear treatment because they are concerned about their sexual health. Reactions vary, and the nurse should maintain a sensitive and non-judgmental approach to education and support for the patient, and the nurse should interview the patient about his pre-treatment level of sexual function. The nurse should teach the patient about the actual or potential effects of therapy on the sexual function and provide an opportunity for the patient and their partner to discuss implications of and concerns about the diagnosis and treatment of sexual function. Discuss the medical and surgical treatments for erectile dysfunction with the patient, and also maintaining sexual intimacy, we have to remember, is essential to a good quality of life. The expected outcomes to evaluate patient care are based upon the goal set during the planning stage and may include using a pain rating scale, and the patient would report managing pain at a tolerable level. The patient is also able to discuss sexual function with his partner. We want that to be the case. The patient lists strategies for managing urinary incontinence. The patient maintains adequate urine output without complications related to altered urinary elimination. And the patient achieves his meaning of a satisfactory quality of life. And this is going to be different for different patients. The patient's spiritual needs are met, and the patient expresses a feeling of acceptance and peace. The nurse will need to provide an open, non-judgmental environment and use therapeutic communication skills to encourage truthful discussion regarding the patient's experiences and concerns. And then the nurse will also need to use compassion in communicating with these patients. And now we have some questions that we're going to review. Question 1. A client who has had a prostatectomy following a diagnosis of prostate cancer is ready to be discharged. The nurse plans to include which information when initiating discharge teaching? And your options are: number 1, notify the physician for any blood in the urine. Number 2, avoid driving for 1 week. Number 3, avoid lifting heavy objects for 4 to 6 weeks. And number 4, decrease fluid intake to decrease incontinence. Your correct answer is avoid lifting heavy objects for 4 to 6 weeks. And the rationale behind that correct answer is the client should avoid lifting heavy objects for 4 to 6 weeks after surgery. And this is a common recommendations for all surgeries. Small amounts of bleeding and clots are normal for up to 2 weeks after surgery. Driving should be avoided for a minimum of 3 weeks postoperatively, and fluid intake should be increased to at least 2 liters per day to limit clot formation and prevent infection for this patient. Question 2. A nurse is providing a program for older men in a senior community about measures that can be taken to reduce the risk of prostate cancer. Which information would the nurse include in the program? Your options are: number 1, increase fiber intake. Number 2, decrease lycopene intake. Number 3, avoid foods high in sodium. Number 4, decrease processed meat and dairy intake. And the correct answer is decrease processed meat and dairy intake. The rationale is some studies have shown an increase of prostate cancer in societies with diets high in processed meats and dairy intake. The other options have not been shown to impact the incidence of prostate cancer. And then your question 3. Risk for stress. Urinary incontinence is a common nursing diagnosis or hypothesis following prostatectomy. Which assessment data would the nurse need to consider to plan appropriate interventions for this diagnosis? And your options are: number 1, client's past Foley catheter history; number 2, client's previous urinary patterns; number 3, types of surgery being performed; and number 4, client's pain tolerance. And the correct answer is client's previous urinary patterns. The rationale for this includes: before the nurse can plan interventions for this diagnosis or hypothesis, the nurse would need to know about the client's previous urinary patterns. Having had a Foley catheter in the past does not affect this diagnosis or hypothesis. Any type of prostate surgery will impact urinary continence, and pain is not associated with incontinence in this surgery.